So let's imagine a situation where a trauma patient he came to your clinic with a severe injury. So you have to find out the most important step. So what you have to do is to conduct what we call as a primary survey. So imagine a situation where a person come in after a car accident. So the first step we take is to quickly assess the patient condition using using a mnemonic that you have to remember is for primary survey we just uh, for knowing the primary survey uh, we should know the mnemonic. The first is A, B, C, D, E. So what does A stand for? The A, it stands for the airway. So we check if the patient can breathe properly. So we will see if there is anything that is blocking the patient airway, like the presence of blood, vomit, or any foreign object, which could make them hard for them to breathe. So if the airway is clear, we move on to B. What does B means? B stands for breathing. Here we will assess how how is the patient's breathing. Are they breathing normally or they are struggling? So this could help us to identify issues like collapsed lung, either rib injury that might be causing difficulty in the breathing. The next step is C. C is circulation. So we will quickly check the patient pulse and skin color to see if the patient might be going into shock due to the severe bleeding or any other issues. So if we notice any sign of severe bleeding, we act fast to control it. Third sign is D. D stands for disability. So we will assess the patient neurological status, like their level of consciousness, if they respond to us, and their movement. This helps us to diagnose the head injuries or spinal cord damage. Finally, the next step is E, that is exposure. We will carefully remove any clothing or obstruction to thoroughly examine the patient for other injuries that might not be immediately visible. So, when a trauma patient he arrives, our immediate goal is to perform this primary survey to quickly identify and manage any life-threatening issue they might be facing. So, the primary survey we have to quickly identify and address the life-threatening issues within a few minutes. Generally, usually 5 to 10 minutes. So, A was to check out any airway obstruction. Now, what could be the cause of this airway obstruction? The first, it could be due to the decreased muscle tone. So, when the muscle in the throat areas they become weak or relaxed, they might not keep the airway open, and that should lead to blockage. The second, if someone vomits or bleed. So, if someone will vomit or if there is blood in the mouth or throat, these substances can block the airway and make it hard to breathe. The third could be due to the regurgitation of stomach content. Sometimes when the stomach's content can come back and block the airway, especially if someone is lying down is unconsciousness is unconscious. The next, injuries or something stuck in the throat can cause blockage, making it difficult for air to pass through. Other reason could be swelling or inflammation or edema. Reasons like infections, allergy, or injury that can narrow the airway and obstruct the breathing. Other reason could be excessive secretion or mucosal edema. If there is too much mucus or swelling in the airway passage, that can also block the flow of air. The conditions, other reason could be bronchospasm or pulmonary edema, conditions where the air passage it tightens or there is fluid accumulation in the lungs that can cause airway problem. Visualize the sign that helps in recognizing the airway obstruction. The first you will see is inspiratory stridor. What do you mean by that? It is a high pitched sound heard during breathing. So it usually indicates when there is problem in the upper airway, like the throat or voice box, that suggests a partial blockage. Second, expiratory means it is a whistling or musical sound heard during breathing. So it typically indicates a problem in the lower airway, like the small tubes in the lungs, and suggests issues like asthma and the bronchitis. The third could be the complete obstruction. So when the airway is entirely blocked, so there is a seesaw pattern in breathing where the chest and abdomen they move in opposite direction. So that is why we call it as paradoxical movement, and it is a sign of severe airway blockage. Other sign is the central sinuses. So it's the late sign which is seen when the lips, tongue or skin it turns bluish due to lack of oxygen. So that indicates a serious problem, and it often appears when the airway obstruction is severe and not allowing enough oxygen in the body. Apart from that, you have to look for the chest and abdominal movements. You can observe the chest and abdomen to see if they rise and fall evenly with each breath. So you have to listen, feel, listen for the airway flow and breath sound by placing your ear close to the person's mouth and nose. You can listen the sound of breathing. You can feel, you can place your cheek near the person's mouth or nose to sense if there is any airflow. So lack of air movement against the skin, it could suggest an obstruction. So what you have to do? Listen, feel and look. Other thing that you can do is you can do a Malampati score. So it's a method that is used to assess the visibility of the person airway structures and predict the potential difficulties that are encountered during intubation or airway management. So the scoring system, it is based upon the visibility of the different parts of the throat. So when the person is seated upright, mouth wide open and tongue fully extended without phonation, that is without making any sound. So the scoring system, it ranges from class 1 to class 4. So when there is complete visualization of soft palate, uvula, tonsillar pillars and entire back of your throat, that signifies a very open airway. So that is classified as class 1. Class 2 is when there is complete visualization of uvula, which is the fleshy lobe hanging down from middle of the soft palate. It indicates a relatively open airway. The third is when you visualize only the base of uvula, that is the lowest part of the uvula near the throat. It suggests a partially obstructed airway. And class 4, when the soft palate it is not visible at all, and it indicates a highly obstructive or difficult to manage airway. Apart from that, other grading system that we use is Cormack and Lehane grading. So it is used during laryngoscopy. So that is a procedure to view the larynx or voice box. So that is used to describe the visualization of specific structures in the throat. That ranges from grade 1 to grade 4. The grade 1 is when the entire glottis aperture, the opening between the vocal cords, it is visible. So that is the ideal view during the laryngoscopy. The grade 2 is a visualization of just the posterior part of the glottis or only the posterior portion of the vocal cords. The grade 3, when only the epiglottis is visible, the vocal cords they are not seen here. And the grade 4, when no structure beyond the base of tongue could be seen. So these are the classification, the grading system that are involved in the airway blockage. Now imagine a situation where emergency medical personnel receive a call about a motor accident. So upon arriving at the scene, they find a patient. Let's call him Aman. So So Aman, who was involved in serious collision accident, and he is unconscious, and he's appear to have suffered injuries to his face and neck. So uh, in this scenario, the medical team would immediately start the primary survey. So the first priority is to manage the Aman's airway due to the critical nature of the situation. So the team quickly recognized that Aman, he is unconscious and is need of an open airway to breathe properly. So they use technique learned in the training to secure the Aman's airway while taking precautions to stabilize his cervical spine because of the potential neck injuries from the accident. Now, a team member would carefully inspect the Aman's face, checking for any sign of injury like blood, facial structure, or foreign object that might be obstructing his airway. So that will ensure that nothing is blocking the pathway for air to reach his lungs. So since the Aman, he is unconscious and he needs immediate assistance in breathing, the medical team would perform techniques like chin lift or jaw thrust to maintain a clear airway without any aggravating any potential neck injuries. So the team understand that the unconscious patient require immediate intervention to secure the airway, whereas the patient who can communicate verbally might not be at immediate risk but still can be continuously assessed. So the Aman finds that his airway might be more complicated due to the bleeding, potential bleeding, unstable fractures, or foreign bodies that are blocking the air passage. So sometimes after an accident, people might be restless because of their injuries. So if the Aman's condition worsen, the intubation becomes necessary to secure his airway. So the team ensures that stabilize his neck and spine to prevent any further damage to the intubation process. The patients who are unconscious, whether due to alcohol or any drug use because of severe head injury. So remember, you have to first do is the Glasgow coma scale. So the Glasgow coma scale score of less than 8 will indicate the person having higher risk of airway compromise. So for your MCQ exam, remember that the Glasgow coma scale of less than 8 indicates a higher risk of airway compromise. For these patients, establishing a definite airway should be priority as soon as to ensure adequate oxygenation as well as ventilation. So while securing the airway through intubation in a trauma scenario, especially for patients with potential cervical spine injuries, appropriate precautions they are vital. That includes maintaining manual inline cervical immobilization to minimize the movement of neck during the intubation procedure until the airway is secured. And apart from that, you can use a cervical spine collar. Apart from that, let us learn how to manage a laryngeal trauma related airway issues. First of all, you have to recognize the laryngeal trauma. The laryngeal trauma, it can be very serious that can block the airway. Signs like hoarseness, air under the skin in the neck, or the neck fracture, it can indicate this problem. So you can use CT scan or endoscopic evaluation to check for the injuries, whether it is hard to examine due to swelling or other tissues. Audible breathing, stutter, that is a high pitched sound during breathing or absence of breathing, it signifies that airway obstruction has already occurred. So requiring an immediate action to secure the airway. Apart from that, you can place in supplement oxygen and monitor using a pulse oximeter. They are important to maintain the adequate oxygenation level. So apart from that, you can give it extra oxygen using a machine, and along with that you can check the oxygen level in the blood. So if a person he can still talk, it usually means their airway is clear. Apart from that, less invasive methods like non-invasive positive pressure ventilation, nasopharyngeal airway insertion, or maintaining the patient position to optimize airway patency might be attempted initially. In severe cases, you can use this advanced airway by endotracheal tube. Now, what are the airway maintenance techniques that are essential to maintain a ventilation temporarily to establish a definite airway? The first approach is the head tilt chin lift maneuver. So this technique involves you have to gently tilt the head back and lift the chin upward. So it helps to clear the airway obstruction caused by the tongue falling backward and blocking the throat. So by tilting the head back and lifting the chin, the tongue it is moved away from back of the tongue, allowing for the better airflow into the lungs. Other method you can perform is the jaw thrust. So unlike the chin lift, the jaw thrust maneuver involves displacing the jaw forward without tilting the head. So it is, remember, it is this situation, it is useful in a situation where there is suspicion of cervical spine injury, as it avoids the movement of neck while still helping to open the airway. Apart from that, you can use this Selic maneuver, that is also known as cricoid pressure. So it is a technique that is used in emergency medicine during intubation process. So what we do here, it is technique that is done to prevent the regurgitation of stomach content into the airway. So what you will do here, you will apply pressure to the cricoid cartilage in the neck. So the primary goal is to compress the esophagus against the vertebra, so reducing the risk of stomach content such as vomit or food entering into the trachea and causing aspiration during intubation. So you apply pressure directly to the cricoid cartilage, that is a ring-shaped cartilage that is located in neck just below the Adam's apple, that is the thyroid cartilage. So the pressure is applied through the thumb and fingers to press down on the cricoid cartilage and simultaneously pushing it against the cervical vertebra. So this pressure it is maintained until the healthcare provider successfully place the breathing tube, that is the endotracheal tube, into the trachea during the intubation. So remember, excessive pressure it can cause difficulty in visualizing the airway during intubation, or it can even obstruct the airway. So it is a precautionary measure that is done during intubation to reduce the risk of aspiration of stomach content into the lungs. Now, what are the artificial use ventilation? We can use is mouth to mouth ventilation. So this technique involves using a pocket mask or face mask to provide artificial ventilation. You have to seal the mask over the patient mouth and nose, and rescuer breathe into that mask. So it will help to deliver oxygen and assist with the breathing in individuals who need emergency respiratory support. Apart from that, 2% bag wall mask ventilation can be used. So in this method, one patient, one person. So in this method, one person would hold and position the mask over the patient's face, while the other squeezes the bag attached to the mask to provide artificial ventilation. Apart from that, we can use this flow restricted oxygen powered ventilation device or 1% bag valved mask ventilation. Apart from that, you can do is the oropharyngeal airway. So oropharyngeal airway, it is a curved plastic device that is inserted into the mouth to prevent the tongue from obstructing the upper airway. So it is used in unconscious patient or those with a decreased level of consciousness. So it should be used in unconscious and unresponsive patient. If you do in the conscious patient, they may stimulate the gag reflex and that lead to vomit or trigger the laryngeal reflex that results in a laryngospasm. So where the vocal cord spasm, it can obstruct the airway. So to insert the oropharyngeal airway, the restor, he opens the patient mouth and insert the curved tube into the back of throat to keep the tongue away from the posterior pharynx and preventing the airway obstruction. So before insertion, you have to first check that there are no foreign bodies or any obstruction that is present in the mouth that could hinder the placement or compromise the airway. Other method is a nasopharyngeal airway. So it is a flexible tube that is inserted through the nostril into the nasopharynx. So it is used in patient with intact gag reflex or in situation where the oral insertion is not possible. So it is a flexible tube inserted through the nostril into the nasopharynx to maintain the upper airway. So it is done in the conscious patient. So it can be helpful in conscious patients with clenched jaws. So in patients with the trismus. So in case where the patient has clenched jaws, that could be due to reasons like seizures, trauma, or muscular issues that leads to so inserting an oral airway might be difficult due to inability to open the mouth. So that is why we prefer the nasopharyngeal airway here. Other is trismus, when patient is unable to open his mouth, so we prefer the nasopharynx airway. Now, what is the contraindication of this? So nasopharyngeal airway. So the nasopharyngeal airway, it is contraindicated when there is evidence of fracture at the base of skull. So inserted a nasopharyngeal airway into the nasal passage involves the navigation of tube along the nasal cavity and reaching the nasopharynx that is close to the base of skull. So if there is an existing fracture in this area, the insertion of this nasopharyngeal airway that can worsen the injury, causing bleeding and potential damage to the vital structure. So that can further lead to neurological complication, hemorrhage, or further trauma. So that is why it is contraindicated when there is evidence of fracture at the base of skull. That is important point that you have to remember for your entrance exam. Remember, other insertion airways are the blind insertion airways. They are the alternative devices that are used for airway control when the traditional intubation methods they are unsuccessful. So what are the blind insertion airways? They are the combi tube, laryngeal mask airway, or kink airway. First of all, what is combi tube? Combi tube, remember, it is a dual lumen airway that can be inserted blindly into the patient airway. So it has two lumen with it has two separate lumen with a different insertion depth intended for the esophageal and tracheal placement. So it is a dual lumen airway device that is used to provide a secure airway for emergency. So remember, it is indicated in case of failed intubation or difficult airway. So combi tube, it is utilized as backup or rescue airway device when the traditional intubation methods they are unsuccessful. Second, it is done in the emergency situations, like in case with the cardiac arrest or other life-threatening scenarios where immediate airway management it is critical. So remember, the combi tube, it has two lumens. Esophageal lumen, the larger lumen, it is intended for insertion into the esophagus. When placed in esophagus, the distal balloon cuff occludes the esophagus, preventing the passage of air or fluid into the stomach. And the proximal cuff seals the hypopharynx to prevent aspiration into the lungs. The tracheal lumen is smaller one. It is positioned in the trachea. If the insertion into esophagus fails, that allows for direct visualization, that allows for the direct ventilation of trachea, delivering air to the lungs. Now, it is contraindicated in patient under 5 feet taller or under 14 years due to concern about proper sizing and fit. It is avoided in patient who has ingested caustic substances, those with esophageal trauma, as it can further damage or cause complication. Not recommended for patients with an intact gag reflex, as it may trigger gagging or vomiting. So remember, combi tube, it is an emergency airway device that is used in a difficult airway management, particularly in situation of cardiac arrest or cardiopulmonary emergencies. So combi tube, we discussed that it has two balloons, the distal and proximal balloon. The distal balloon requires 10 cc of air for inflation, while the proximal balloon, it requires around 80 to 100 cc of air for proper inflammation. Other is the laryngeal mask airway. It is a supraglottic airway device that is inserted blindly into the pharynx, forming a seal around the larynx inlet. So it sits above the glottis, allowing ventilation and oxygenation without requiring passage through the vocal cord. So its use is associated with improved hemodynamic stability during the anesthesia induction. It minimally affects the intraocular pressure, and it can be preferred in eye surgeries where raised pressure can be an issue. It might lead to reduced anesthesia requirement in some cases. The disadvantages are its inability to provide complete seal around the trachea, make it less effective in preventing aspiration. There is potential risk of gastric, so there could be increased risk of regurgitation. It can have air leakage during positive pressure ventilation. Other is the King's airway. It is similar to other supraglottic device. It is inserted blindly into the patient airway, and it consists of airway tube with inflatable cuff to create a seal in the oropharynx or hypopharynx, maintaining an open